Welcome here. I'm Dr. PJ Madam Rafi. Today we are going to discuss about antifungal agents. Okay. There are three types of fungal agents will be there. One is systemic agents for systemic infections, systemic agents for topical infections, topical agents for topical infections. Okay. First we will discuss systemic agents for systemic fungal infection. That is drugs used for treatment of systemic fungal infections, because here we are using IV drugs for systemic infections. What are those? First drug will be amphotericin B. It is very important drug. It is a pauline antibiotic, not absorbed orally. Obviously that's why we will give IV only. This IV drug should be given slowly along with dextrose. Okay, that is an MCQ. Next, this amphotericin B is widely distributed all over the body except CNS. It won't show any effect in central nervous system. Okay. Main action of amphotericin B in fungal will be, it mainly binds to the ergosterol. It is a fungal cell membrane main component. Okay. It binds to the ergosterol and it causes formation of artificial pores. It causes pores in the cell membrane of fungal. Okay. When they form pores, obviously the cell's intracellular liquid will be flushed out and it will become shrink and it will be dead of the fungal wall. Okay. Fungal body. Okay. So it will form, it binds to the ergosterol and causes formation of artificial pores. They form artificial pores in the fungal cell membrane. There how it will cause, leads to the death of the fungal. Okay. It is drug of choice for cryptococcal meningitis and mucormycosis. Okay, these are the drug of choice of cryptococcal meningitis and mucormycosis. ADRs will be infusion related infection reactions. That means infusion, because these are highly toxic drugs. So we have to give very slowly, and we have to be give some drugs to prevent the inflammatory reaction like antihistamines and glucocorticoids before infusion. Okay, we have to give these are as a precautionary drugs. Okay, because these are toxic drugs, they can cause inflammation reaction. That's why we have to prevent by giving antihistamines or glucocorticoids. Okay, this amphotericin B is a nephrotoxic, obviously toxic drug, and it will cause anemia also. Okay, this is regarding amphotericin B. Amphotericin B should be given slowly along with dextrose. Main action will be formation of artificial pores in the cell membrane, that fungal cell membrane. Okay, therefore it will used to cause leakaging of intracellular fluid, thereby it will cause death of the fungal. Okay, that is regarding amphotericin B. Okay, next drug will be liposomal amphotericin B. It is a safe and less toxic. There are two types of liposomal amphotericin B will be there, that is colloidal dispersion type and lipid complex type. Okay, these are safe, that's why we can use in nephrotoxic patients also. Okay, it will cross blood-brain barrier also. Okay, this is liposomal, so it easily crosses blood-brain barrier, so it will have more beneficial effect compared to the amphotericin B. Okay, next drug will be flucitocin. Okay, flucitocin. It is a flucitocin. It inhibits, that means 5-fluorouracil. Okay, flucitocin inhibits DNA synthesis by inhibiting enzyme thymidylate synthase. Okay, it is shows synergetic effect when you are combining with amphotericin B. It is effective against cryptococcus and candida infections. Okay, adverse effect of flucitocin will be that 5-fluorouracil will be bone marrow suppression, alopecia, liver dysfunction. Okay, this is regarding flucitocin. Okay, next drugs will be azole. Azole will also very important. Okay, first one amphotericin B, flucitocin and azoles. Azoles inhibit 14 alpha demethylase. Okay, it inhibits this enzyme. This enzyme will be useful for conversion of lanosterol to ergosterol. Ergosterol is a main component in formation of cell membrane. Okay, when this cell membrane will not be formed, obviously leads to cause death of the this one fungal. Okay, so obviously by inhibiting 14 the alpha demethylase, it will inhibit formation of cell membrane. Okay, these azoles will have opposite action of amphotericin B. What is the main opposite action means? Amphotericin B will be effective when there will be cell membrane. Okay, if there will be cell membrane, it will cause artificial pores. These azoles are preventing to form the cell membrane. Okay, that's why when you are giving these two at a time, obviously when there is no formation of cell membrane, how amphotericin will be become effective? That's why they both have opposite action, so we shouldn't combine these two drugs when you are treating fungal infections. Okay, why means azoles will inhibit 14 alpha demethylase, thereby inhibit cell membrane formation. Okay, Important drug in azoles will be ketoconazole. It is having narrow spectrum and it is a mainly enzyme inhibitor. Okay, main adverse effect will be gynecomastia. It's most commonly asking MCQ, gynecomastia, and it is enzyme inhibiting property. Okay, next. Next will be fluconazole. Fluconazole having maximum oral bioavailability. Okay, that's why we'll use most commonly as a maintenance therapy, because after amphotericin or liposomal amphotericin or 5-fluorouracil treatment IV medication, these are oral drugs, we'll give as a maintenance therapy. Okay, it is having maximum oral bioavailability, CNS penetration also there. So mostly all infections like Candida, Cryptococcus, coccidiosis. Okay, these 3C infections like Candida, Cryptococcus, coccidiosis, these all infections we will use fluconazole as a maintenance therapy. Okay. Next drug will be in azoles itraconazole. It will drug of choice for blastomycosis, histoplasmosis, coccidomycosis, and sporotrichosis. Okay. So this is the drug of choice. This is the itraconazole drug of choice for these following complications. Okay. So you have to remember the names. Okay. Here mind these two drugs, fluconazole very important, and drug of choice itraconazole are important. Next. Next important drugs in azoles will be voriconazole. It is having wider spectrum. Okay, ketoconazole will having narrow spectrum. Okay, it is having wider spectrum among azoles except mucar and sporotrichosis. These are not effective. Okay, so it is drug of choice for invasive aspergillosis and fusarium infections. This voriconazole adverse effects will be visible disturbances, blurred vision, photophobia, altered color perceptions. Okay, and it will also cause prolonged QT intervals and squamous cell carcinoma. So should be cautious when you are giving in patients, because of they are having more chance of ADS. Okay. Next azole will be posaconazole. This is recently we are hearing more commonly in mucormycosis cases. Okay, it is effective against mucor cases. That is mucormycosis in COVID or some normal mucor cases also will use posaconazole. It is a orally available drug, because amphotericin B, liposomal amphotericin B, those are liposomal amphotericin B will be safe. If you are patient shifting from IV to oral, we will use posaconazole for mucor cases. Okay, because amphotericin is very highly toxic, that's why we will not use in all cases. Okay, next group will be echinocandins. Okay, we completed three: amphotericin B, second one will be 5-fluorouracil, third one will be azoles. These are systemic drug used for systemic infection. Last one will be echinocandins. Echinocandins will be drugs like caspofungin, micafungin. These are end with fungin. Okay, fungin end with fungin means these are echinocandins. We have to remember the name. They are asking which of the following is echinocandin. Okay, so by name end with fungin, these are echinocandins: caspofungin, micafungin, annudola fungin. Okay, inhibits beta 1,3 glycan in fungal cell wall. Okay, they were used in aspergillosis resistant to amphotericin B or voriconazole. That means the fungal which is resistant to AMB or amphotericin B or voriconazole will use echinocandins. Okay, next. Next is systemic drug for superficial fungal infections. Okay. Previously we discussed with systemic drugs for systemic infection. These are systemic drug we are giving IV route, and these will acting as a superficial infections. What are those? Griseofulvin. Griseofulvin is mainly distributed in stratum corneum. It acts by interfering with microtubule formation, that means cellular division in the DNA level. That's why it mainly inhibits interfere with microtubule function in dermatophytes. Okay. Next is inhibit synthesis of nucleic acids. These drugs will have absorption property. Their absorption property will be increased when you are giving combining with fatty meals. Okay, when you are taking fatty meal, these drugs will have more absorbability. That means they will enhance more bioavailability. Okay, and this griseofulvin will cause disulfiram reactions. Adverse effect of griseofulvin will be GI disturbance, nausea, vomiting, diarrhea will be there, and these drugs also cause photosensitivity. Okay, this is regarding griseofulvin. Next, allylamines. Allylamines will be examples like terbinafine, naftifine, butinafine. Okay, these are fungicidal agents. They inhibit fungal cell wall. Okay, they inhibit squalene epoxide. Okay, this is an enzyme that is inhibit squalene epoxidase. By inhibiting this enzyme, what will happen means decrease in formation of ergosterol. The ergosterol is the main component formation of cell membrane. Okay, so when the cell membrane will not be formed, obviously it will lead to cause death of the fungal. So it will inhibit squalene epoxide. It is a sequential process. Okay. So in the sequential process, it will inhibit the primary step, that is squalene epoxidase enzyme. Thereby, it will decrease ergosterol synthesis. Due to inhibition of squalene epoxidase, it will lead to accumulation of a toxic metabolite, that is squalene. This squalene will cause toxicity to the fungal, thereby it will cause death of the fungus. Okay. So allylamine will be fungicidal. They inhibit fungal cell membrane by inhibiting ergosterol synthesis, by inhibiting which enzyme? Squalene epoxidase enzyme, by accumulation of toxic metabolite, that is squalene. Okay. Another drugs will be azoles, ketoconazole, fluconazole, itraconazole. These are also effective in superficial fungal infection except voriconazole. Okay. This is regarding systemic drugs for superficial fungal infection. Here main important thing will be griseofulvin in interfere with microtubule formation. Next will be allylamine. Allylamines will be terbinafine. These are mainly inhibits squalene epoxide. Squalene epoxide will be decrease in formation. When you are inhibiting squalene epoxide, it will decrease ergosterol synthesis. That means cell membrane, it is main component. So when it inhibit cell membrane component, second thing is it will also cause just toxic metabolite accumulation. Okay. When this toxic metabolite squalene will get accumulated, it will lead to cause death of the fungus. Okay. That is regarding superficial fungal infections. Next is topical drugs for superficial fungal infections. These are, you have to remember the names. That is enough. If they ask, you can remember the names. In this, main thing is nystatin. Okay, nystatin is a polyene group. Next, in imidazole group, we'll have meconazole, iconazole, clotrimazole, ketoconazole, terconazole. Okay. Next, allylamine, terbinafine, butanafine will be used as a topical. Means we'll have a topical agents. Next, benzoic acid, salicylic acid in the combination will be known as Whitefield ointment. This is a MCQ. Whitefield ointment means benzoic acid with salicylic acid combination. Next will be tolnafate, uh, tolnaftate and anticyclinic acid. These are the some newly agents which are used in a superficial fungal infection. Mainly here will be nystatin, one with thing. Next, Whitefield ointment, that is benzoic acid along with salicylic acid. We called as a Whitefield ointment. Okay. This is regarding antifungal agents. You have to remember. Thank you. These are very important topic. You have to remember it. Thank you.